Welcome everyone and welcome to this webinar on quality improvement. I'm Lisa Yates, the Stroke Link Coordinator for Queensland, and I'm so glad you could join us today for what promises to be a very informative webinar on QI in stroke. Joining me today is Melita Stirling, the Quality Improvement Manager at Stroke Foundation. Just before I hand over to Mel, a little bit of housekeeping. We'd love to know where you're dialing in from and your role, so please use the chat to let us know. Throughout the presentations, you can add any questions to the chat and our team of presenters will answer them at the end of the presentation. So I'll now hand over to Melita, who will kick things off.
Thanks, Lisa. Before I begin, I'd like to respectfully acknowledge the traditional owners and custodians of country throughout Australia and acknowledge their continuing connection to land, water, sky and community. I pay my respects to peoples, cultures and elders past and present, for they hold the memories, culture and hope of their peoples. And I also want to acknowledge that I'm joining you today from the lands of the Darug people here in Sydney, and welcome in Darug is Warami Welmabami, meaning welcome wherever you're from. I'm presenting today with two esteemed colleagues who many of you will know, Professor Helen Dewey and Julie Morrison. Helen's a stroke neurologist and senior medical advisor for strategy and improvement at Eastern Health in Melbourne. She's also the current chair for the Oscar Management Committee and the chair of Stroke Foundation's Clinical Council. Julie is the National Program Manager for the Australian Stroke Clinical Registry, otherwise known as Oscar. So welcome to you both. So today we're looking at what quality improvement or QI is and how you do it. I'm going to talk briefly about frameworks that you can use to set your program up and also go through a step-by-step process for doing a QI project. In the middle, we'll have Julie and Helen who will share their expertise about a couple of areas that are really critical to the success of any quality improvement initiative. Helen's going to give us insight into getting buy-in from managers and executives, and Julie is going to present on data, the driving force behind any QI. And then we'll have some time for questions at the end. So I want to just acknowledge the expertise of everyone who's online here today. We see a lot of commitment to improving patient care from all of the clinicians that we work alongside of. And some of you I know are very skilled and experienced in this space. Others will be newer to quality improvement. But this webinar will be most useful for those who are just starting out or perhaps looking for a refresher. So I'm going to start by defining quality improvement. So when we're talking about quality improvement, what are we saying? There are lots of definitions out there, like the one on the slide, but in a nutshell, it's being guided by data to make systematic changes for the purpose of improving healthcare. So where does this all fit into the big picture of the learning health system? This diagram shows all of the components that belong within that learning health system, which is basically just how we all work together to get evidence into practice. So we've got up the top here, we've got research that's happening, that gets turned into evidence. The evidence then becomes recommendations here in the guidelines. Guidelines get turned into indicators so that we have an agreed things that we are going to measure for care. We then have data collection systems and feedback mechanisms so we can see how well practice adheres to the evidence, whether it's evidence-based practice, and to the guidelines. We then know from any gaps that we see, well, we know first of all what's working well, and then we can see where gaps are, where we might want to focus our attentions to do some quality improvement over here. So once we do those projects, we have some outcomes which we then share with the other people who we work with in the stroke community. So all of these elements are interacting and they all support quality improvement. This is an evidence-based process, and all of the elements here are underpinned by frameworks and methodologies, to maximise the accuracy and usefulness of whatever it is in each stage that's being produced. So the same goes for QI, as well as expertise in delivering healthcare. We need to understand and apply the science of quality improvement or implementation science if we're going to make really meaningful improvements and affect ongoing change. So that's where theoretical frameworks come in handy, and I'll only touch on these briefly, but frameworks, they're basically what helps you set up a project and ask the right question so that you can take the right steps to succeed. So there are plenty of step-by-step guides for doing QI around, and you might just choose one of those and not sort of think about it, but frameworks do underpin those guides. And if you're using a guide for doing QI, you really want to make sure that it covers 4 things, which are the evidence, what's the evidence for the change that you want to make, the environment, you need to consider where it's happening, who's involved, and of course, how you actually go about making the change. So just a couple of examples are the theoretical domains framework and the Paris framework. These are both components of the step-by-step guide that I'll talk about at the end. One of them, theoretical domains, looks at behaviour, so all of the different parts of the health system and how that impacts behaviours on delivering care. And the other one is more focused on this very broad view of health and what impacts care from a whole of society or from an organisational perspective. So they're both very useful frameworks to help guide us. So speaking of the complexities of care that Paris addresses, healthcare certainly is a complex beast, and I do particularly like this quote that I've put on the slide here from my favourite QI guru, Kathy Balding: "Great care is delivered by great people in a great system." So clinicians need a supportive environment that allows protected time, education, skills training, and resources to do QI effectively. And this is one of the wicked problems in health. How do you get that? So Stroke Foundation and the Florey advocate for change at a systems level. And advocacy might be something that you want to consider too at a site level. So just thinking about your own hospitals now, what's the approach to QI at your hospital? What's the culture like, you know, when you think about creating change or doing projects for change? And if you wanted to do one, anything from, you know, behaviour change in clinical practice right through to looking at more complex or systemic problems, would your management and would your executive be on board? So what can you say to get their support? Professor Helen Dewey has some considerable experience in this space, so we're lucky to have Helen here today to share some insights with us about that now. Thanks, Helen.
So thank you, Melita, and it's my pleasure to join you all. I can see that there's some veterans of quality improvement online and some names I don't recognise. So I'm going to talk without some slides just to give my thoughts about how you do manage to make a difference within your health service. And I think, as Melita said, it's important for you to do a bit of your own research if you're not aware how your health service goes about its quality improvement and who are the people who might support it and what types of methods and supports there are. It's good to be looking into that because different health services in different states do things in different ways. But I think if you're looking for your executive to be interested in improvement in stroke, you have to be able to talk their language. And the language of the executive team and CEO of a hospital are quite different from us as clinicians at the coalface, where, you know, our focus is on providing the care that an individual needs at the time that we see them. Whereas our executives are driven by much higher forces, if you like, and some of the constraints that come from how health services are governed and are funded. So Melita's kindly put on the slide here two very important documents that are important for guiding evidence-based healthcare, but also important for health services delivering their obligations in terms of accreditation of the hospital in the accreditation cycle and meeting the clinical care standards. So what I would say is that if you are worried that you are finding a gap in your care, perhaps you've got some data from Oscar, as Julie will show you, and maybe your patients are not all getting to your stroke unit, although you'd like them to. Well, I think the important thing is, first of all, to contextualise that. And if you're trying to make a pitch for having assistance with a quality improvement project or putting forward a business plan, it's important to explain to the executive why your area is important. So the evidence is where you start, that you've got evidence-based practice and what the gap is. And also, you then need to think about what the levers are that are important for the executive. So we know that stroke unit care makes care more efficient. So you're going to be interested in the effects on length of stay and flow through your emergency department and discharge planning and hours waiting and all the things that your management team in the hospital are interested in performance every day. They also have, all the health services, as many of you will know, have obligations to their funding Ministry of Health, and among those obligations are meeting targets with things like patient experience, and so being able to have additional data to support that your patients may not be having an excellent experience because they're not getting to the stroke unit, they're spending a long time in the emergency department, gives a reason to concentrate on your area for improvement. And what I would really encourage you to do is to think about what your elevator pitch is. If you have the opportunity to be in the lift or passing by the chief executive or the operations manager in your area, how you actually talk about stroke care and the bit that you do and the things that you're proud of. Because one really important thing about contributing to Oscar or to some other regular data collection process is that you can show yourselves as real poster girls or boys to your executive because you're helping them meet standard 1 in accreditation, which requires health services to have systems and processes whereby they're monitoring and ensuring that quality evidence-based care is being provided. So I'm not going to say much more, but I think it's good to be thinking about the words that our executive focus on, couching your problems in relation to standards and priorities in your hospital strategy, and making sure that you've got evidence to support the concern about a problem, and then trying to see that you can get help from whoever is involved with improvement in your health services. And health service improvement teams are always interested in working with people who are passionate about improvement and want to get in there and make a difference. So I'll stop there and hand back, I think, to Julie.
Thanks so much, Helen, for that excellent information. I'm sure that'll be very helpful. And if anyone does have questions that they'd like to ask Helen, please do put them in chat now, and there'll be an opportunity to speak more about this at the end. So we're going to hear from Julie now about the need for data-driven insights into quality improvement. Thanks, Julie.
Thanks so much, Melita, and thanks, Helen. That was an excellent presentation. I've written a page of notes here. So yes, I'm the program manager of the Oscar, and I'm going to be talking a bit about the need for data and why that's important when you're starting off a quality improvement activity, as well as the importance of tracking it along the way. So next slide. Thank you. So although we have strong evidence for acute stroke care treatment, so Helen mentioned the acute stroke clinical care standards that give an indication of what good acute stroke care looks like. We're also lucky in stroke to have the Stroke Foundation's living guidelines that are updated as new evidence comes available. So we have really good evidence for what good stroke care looks like. We know that there is significant variation between hospitals. So I'll just bring up a graph here. And this is an example from one of our recent annual reports. And this is showing each of the bars here represents one hospital. And this is looking at median door-to-needle times. But we see similar trends with other indicators. So you can see on the left-hand side of the graph, we have a hospital that was able to achieve a median door-to-needle time of less than 45 minutes. And conversely, on the right-hand side, we've got a couple of hospitals that are up around 160 minutes or so. So there's really significant variation in care. And we know that reducing that variation is essential to avoid deaths and unavoidable disability. So we know that the target for median door-to-needle time is 60 minutes, and we're not just aiming for 60 minutes because we want to meet that target or we want to move to the left side of the graph. It's really important to remember that what we're talking about is improving the lives of the patients, that every minute for door-to-needle time really counts in getting better outcomes for patients. So this is a quote that I quite like, that without data, you're just another person with an opinion. And you working on your stroke units may well have a really good idea of what's happening, and you may have opinions about areas where you may be performing well or performing not so well. But without the data, there may be other people that have a different opinion to you, or it may be hard to convince executives, like Helen's spoken about, without the data to back up what your thoughts are. So having the data gives you that objective evidence. So any systematic collection of data gives you that evidence of how your treatment is going, or in terms of outcomes. And it also allows you to identify areas requiring improvement. And just the next little bit. So any data collection is important, but because I'm from the registry, I will argue that contributing to a clinical quality registry adds additional value. So it provides access to standardised data reports, as well as live reports or dashboards where you can interrogate that data a bit more. It gives you that ability to monitor change over time because the data are entered on all patients. And importantly, provides that ability to benchmark and compare with other hospitals. So in the registry, we will report on achievable benchmarks, and we calculate that from the top performing hospitals for each of the indicators that we collect. So it's not always the case that we're expecting 100%. It's always a good idea to look at the achievable benchmark for what other hospitals have been able to achieve for those indicators. And I've just included on the left, another sort of example of that learning health system that Melita was talking about earlier, and how data is important, and that helps inform the quality improvement, and the cycle goes round in terms of improving the quality. Thank you. So where to begin? It can seem a bit overwhelming, and like I said, you may have thoughts of areas that need improvement from your work within your stroke unit or with stroke patients at your hospital. But one example that I'll give from the registry is that the stroke performance scorecards that we send out to every participating hospital at the close of the previous year's data. So this year, in June or July, we'll be sending out the reports for 2023. And this provides a snapshot of how your hospital is performing against each of those indicators that are captured. So we also provide later in the year a more detailed hospital performance report that is about 23 pages or so. But this was designed particularly with executives in mind that may not have time to look through the 23-page report that you may be interested in, so that you can see at a glance how your hospital is performing. And we use a traffic light system where red is the lower performance, where the red here is a low outlier that's 3 standard deviations below the average for that period. And then that goes all the way up to the dark green star, which is hospitals that are contributing to or above the achievable benchmark. So when you receive this report, the first thing we would say is always a good idea is to celebrate success. So have a look at those areas where you're doing well and make sure the members of the team involved in that area know that you've done really well, that you're one of the top performing hospitals in that area. And then, of course, it's important to review areas of low performance. So it may not just be those ones where you have the red or the amber circle. You might also want to look at changes over time. So for this hospital example, the thrombolytic delivery in 2021 was at 20%, and then that dropped to 10% in the second year. So although that's still at the average, it's significantly changed over time. So that might be something that you'd want to dive in a little bit deeper. It's important to think about your local context. So something like proportion of patients thrombolyzed, that may be, if you're in a regional area that has a large catchment, you may be getting patients arriving outside that 4.5 or the thrombolysis window more often than in a metropolitan hospital. So keeping in mind your local context is important when looking at these reports. Ensure you understand the data. So some of these calculations have some intricacies in terms of what's included or excluded. So in all of the reports we provide, there'll be a little appendix that shows you all those calculations. It's also important to know whether the data are representative. So for example, have you included all stroke patients in your hospital or just those that made it on a stroke unit? One way that we look at that in the registry is by looking at case ascertainment. So that means that of the patients that came to your hospital and were coded as an acute stroke, what are the proportion of those that ended up in the registry? So for this hospital in 2022, they had 99%, which is really excellent. Also important to consider whether the data you provided were complete. So generally, if there's no answer recorded for any of these indicators, it's assumed that it wasn't performed and it's counted as a no. And if more than 30% of data are not included, then they're not shown in this scorecard. So making sure your data is complete is important when looking at these. And then you might like to consider taking a bit of a deeper dive and looking at some of these metrics in more detail. So in the middle of last year, the OSCAR released its first interactive dashboards, and we're continuing to release those. We now have 6 available. And the great thing about these is the filters up the top. So you can look by different years, you can look by stroke subtypes, you can look by transfers and in or out of hours. And there's a range of filters that are appropriate for each dashboard. So I'll just give you an example on the next slide. So say you looked at your scorecard and you thought you'd really like to improve your daughter needle time. You'd love to get it below that 60-minute target. So you look, this is a 2023 example, and your median is 68 minutes. So you're not too far off. And then you might want to drill down a little bit and have a look at your in versus out of hours. So if we just look at the in hours, apart from a little blip around May, the in-hours daughter needle time is actually very good at 47 minutes. And then if we look at the out of hours, you can see that there's a significant difference and the median now is up at 92 minutes. So if you were thinking about improving your daughter needle times, drilling down a little bit into the data and understanding where the variation lies will be really important to focus your quality improvement activities. There are some other things that you can do to drill down a little bit more into your data. So the first is considering a chart review. So the data are great, but can only provide you with a certain amount of information. And there may be things that you can only get from looking back through the patient medical records. So for example, there may be a subset of patients who haven't received antihypertensives on discharge, and you may be surprised by that or wonder why that is. So having a look at all of those patients who didn't receive that, those antihypertensives, and understanding why. So sometimes we find it's a documentation issue, that it's not recorded consistently or it's recorded in different places. So that's something to look at. And then you may find other underlying reasons for this variation. There are also within our tool the ability to export your data in an Excel spreadsheet format. So we think the need for this probably is reduced with the dashboards, but if you wanted to look at the data in different ways, then that's always available to you. And then the Stroke Foundation audits provide a bit of a deeper dive than what's available in the registry. There's a larger set of variables. So taking a look at that and those extra variables may provide some extra information for you. The Stroke Foundation also have spot audits that are available in the AusDat platform where the registry sits on things that are not generally captured within the audits or the OSCAR. So that can all be helpful to add information. The last thing I'll say is that data quality matters. So the quality of the data that we're reporting back to you will depend on the quality of the data that is entered. So there's a saying of rubbish in, rubbish out. So to try and make sure your data quality is as good as it possibly can be, we'd recommend you become familiar with the data dictionary. Or if you're not using the OSCAR, there is the National Stroke Data Dictionary that encompasses a wider proportion of variables. Ensure that everyone collecting the data is understanding and interpreting it in the same way. We've heard a few examples from hospitals, particularly around brain scan or first CT times, that this is sometimes recorded in different places in the medical record with differing times, sometimes significantly different. So making sure everyone's collecting the information from the most accurate source. And then if you're participating in the OSCAR or a similar program, using the data quality reports that are provided by the registry is really beneficial. We provide 2 formal reports every year identifying episodes that have discrepancies. And now within the dashboards, we have on each dashboard a data quality tab, and that updates every day with lists of patients or episodes that have discrepancies in their data. So you can keep on top of your data quality by using those as well. So that's all from me, and good luck with your endeavours in quality improvement.
Fantastic. Thanks so much, Julie, for the very informative presentation. And once again, if anyone has questions for Julie, pop them in chat now and we'll come back to them shortly at the end of the presentation. So now we're just going to take a quick look at the process for doing a quality improvement project. So the slide that you can see is taken from the QI to Go course. It's run by the Australian Council on Healthcare Standards. And the diagram gives a nice overview of the process for clinical practice improvement. So you've got your starting point as at the top, recognising that problem. And then next is planning your project, then on to a diagnostic journey when you delve into what the cause of your problem actually is. Then you go to the third phase, the intervention phase, when you're testing ideas for improvement. And then you are measuring these, of course, because you want to be able to show the impact of the change. And finally, you're standardising your new process so that you can sustain any improvements. So let's have a look through each step or each phase. And the first phase, first part is the project phase. So this includes what you want to change, deciding on that, gathering a team together, writing a SMART goal, and deciding how you're going to measure your changes. So in terms of deciding on an area to improve, this of course is driven by data. Some key considerations when you're picking the improvement area is where is the evidence practice gap, and where are the gaps and which are widest. These have the greatest potential for improvement. You also would like to think about which gaps have the biggest impact on patient outcomes. So some areas are more critical to overall outcome than others. So stroke unit care, for instance, is the single most important element in stroke care in terms of patient outcomes. You also want to think about what the priorities of your hospital are or of your department. It might be easier to get that support and the resources you want if you're working on identified priorities. And also think about where you might have some quick wins. So an improvement project that is short-term, that doesn't use too many resources, but it's got a high impact, might get better buy-in for you than for something that has higher resource demands. So the next thing to think about is who you're going to need on your project team. You will need a couple of people to guide and support the project team at the management level. Ideally, they'll have access to resources that they can provide you with. And also, it's best if they've got some sort of stake in the process so that they have an intrinsic motivation to drive it forward with you. In the improvement team itself, you need somebody who can lead. So somebody with a strong interest in solving the problem and also who's good at working with individuals and groups. Within the membership itself, you need all of the knowledge from different systems, so clinical, organisational, process of care, patient experience as well. Those are all important pieces of knowledge to bring. And the group itself needs to have members of the different groups to be representative. So if you're looking at improving code stroke, for instance, as well as your stroke team, you're going to need people from radiology, emergency, triage, and ambulance. There's no point trying to change processes if you don't have the right people in the room. So group members also need to be able to participate in meetings and other project activities. So one more thing to think about here is influence. So who have you got in your team who is influential with other people and who knows how to bring other people along with them? So once you get your team together, you can set your goal. Goals should be, of course, in the SMART format, specific, measurable, achievable, relevant, and time-bound. That way everyone is very clear on exactly what will be achieved, to what level, by whom, and when. And I'm sure that, many of you are very familiar with these. I thought this was a nice example on the slide here. The original format of this goal was that the stroke team would increase the number of patients that receive a discharge care plan, and that was then put in the SMART format. The stroke team will increase the percentage of stroke patients who receive a discharge care plan prior to being discharged home. It will increase from 36% to 55%, the state average, within 6 months, which is August 2024, and then to 70%, the Australian average, within 12 months by February 2025. So the highlights show the purple is who's involved and what will be done, yellow shows the measurement, blue is how it's relevant, the green tells you when. So all of the boxes for a SMART goal have been ticked. And for anybody who's interested in templates for SMART goals, we'll put a link to our website where you can do that after the webinar. Right, so you've got your problem and your team and your SMART goal. The next phase is diagnostic. It's about finding the cause of the problem. So it's really common at this point for people want to jump forward straight to solutions, but this really is an essential part of the project. If you don't sort of fully understand and see all the intricacies of your process, you're not going to find the most appropriate solutions. So there are any number of ways that you can diagnose where the problems are. Obviously, it's going to, you'll be guided by whatever the area is that you want to improve. But I'm going to look at two particularly useful ways of diagnosing problems, and those are flowcharts and brainstorming. So with flowcharts, these are often recommended as the first step in a study. It gives you a systematic visual display of the components of a process. So it shows where things are happening, the decision points, the order that things happen in, the relationships between the parts. And in some instances, it might also be useful to make a note of the timing of each part that the process takes and to have that on your chart too. So if you use this process, do make sure that what you're putting down is a representation of your current process and not the way that you would like it to be. And also be prepared for the flowchart to reveal that the process doesn't operate the way that you thought it might, which can often be the case. So once you've got that full understanding of how things are currently working, you can use the flowchart to consider where your barriers and enablers are. So what's helping your process and what's hindering your process. And a good way to do this is brainstorming with your team. So a particularly effective way of generating ideas quickly is to do it silently with sticky notes. So everyone gets one sticky note, writes down the idea, and you use as many as you like until everyone has all of their ideas out. It's a good idea at this point to remind the team that you're looking for barriers and enablers and not solutions. You can also give the team some themes to help with the brainstorming if you like. So you might ask them to think about policies or resources, communication, documentation, etc. Again, depending what the process is that you're looking at, you might want to display something like this for that brainstorming session that just looks at different levels of healthcare, where problems might be at each level, and it gives some examples as well. So you're looking during this exercise to develop a list of what's working well, but also to draw out where all of the problems are. And you'll end up with a big collection of sticky notes if you use this process like this, and you'll probably have some double ups. So the first thing you would do is get rid of those double ups, grab your enablers and put them off to one side and focus for a moment at this point on the barriers. So you can give them all some order. They often fall into certain themes or categories. So grab the ones that fall into a similar category and group them all together, like the second picture here. So once you've got all of your problems on the table and you've given them some organisation into categories, it's time to think about which are the priority areas for change. One way that you can do that if you don't have an instant consensus is to give everyone a set number of votes. And in this method, it's usually about half of the number of problems displayed, and that moves some problems to the side, whichever ones aren't voted for are considered less of a priority. If you need to prioritise further, you can use weighted voting. So in weighted voting, everyone gets a number of votes, but this time they can distribute them one per area or one per problem, or they might want to use all of their votes on the one priority problem. You might also want to use Pareto charts. These help visualise the relative importance of problems. So the principle behind this chart is that there are many things that contribute to a problem, but there are just a few that are causing most of the problem. So it's separating the causes into two categories. You've got the vital few and the trivial many. So it gives you a clear indication of priorities once again. These are really easy to use. There are great online templates for these too, so that's something else that we'll share at the end. And there are instructions as well. So once you have gone through the diagnostic phase and you've got your priority areas, it's time to develop some solutions. And the really important aspect is that they're local solutions, that they're specifically tailored to the problems that have been identified in your process at your site. So you're the experts in your site and how you deliver care. So these solutions come from the team who have input in the care. It comes from consumers who can feed back their experience and expertise, their lived experience. It could also come from the experience of others who have made improvements in the same area. Or you could also look at the literature about this process of care or about the effectiveness of particular types of change or improvement strategies. So you could use charts like this that look at barriers, known barriers and possible interventions. You could also look at the effect sizes or the median effect sizes of the types of improvement interventions. So this chart is just showing how much change you're likely to get. So, for example, if you provide educational meetings, you might expect a 6% change. If you provide tailored interventions, on average, you're going to get 1.5 times more effect than you would if you had generic interventions. And to state the obvious, using multiple interventions is better than just using the one. So then there are certain practicalities to consider as well. What can you actually change right now? So you might want to refer back at this point to the list of enablers that you got in the brainstorming session and consider how the things that help your process might be leveraged to help you make the improvements. So determining which things you're going to test to make an improvement, think about, will it be easy or will it be hard to implement? Will it cost a lot? Can it be tested relatively soon? How long is it going to take to test and implement? And will many people have to be educated and retrained to do that? And finally, we are at the intervention phase, which is where you put together your action plan and you then test your ideas in PDSA or similar cycles. So your action plan is going to involve all of the information that I've discussed so far, everything that you've gathered, and also you're going to put in a project timeline that includes the planning for each one of the individual test cycles that we'll look at in a moment. It's going to include the communication about the project. Before you start the project, you want to communicate to everyone and anyone who might be impacted by it. And finally, it will have the actual plans for testing the changes. So now for the actual testing of change ideas, and I'm sure many of you will have familiarity with the PDSA or Plan, Do, Study, Act model. Again, there are templates you can use that I'll share afterwards. So PDSA is a very common methodology for improving care, and it uses small steps to test change and to see if they're going to get the results that you hope that they will. So you start by saying what your objective is and predicting what's going to happen if you implement your change idea. So let's say your objective is you want to improve the readability of patient discharge care plans. Your prediction might be that you'd get a 10% improvement in readability and 20% improvement in patient satisfaction with the plan that you've got. So that might be testing, providing education to staff who contribute to discharge care plans. And the education would include, writing in plain English, removing acronyms, removing medical jargon. So you plan to do that education next Monday, and you're going to do that with the social worker and the physio. So then you carry out your plan, you make a note of any problems like staff illness or busyness that stops them from doing it the education session. You're gathering data as you go so that you can review it and compare it to your baseline. So perhaps you did a file review to get your baseline to assess how easy it was to read these discharge care plans before you started your project. So you're going to then go back and you're going to collect the same sort of data after you've implemented your change and then you're going to do a comparison. So, you're going to look at those sections written by the people you educated and see, has my education been effective? So if your intervention was successful, the next thing to do is scale it up, provide the education to the whole stroke team, and then if that works, take steps to embed this process into your practice. So you want to formalise it into policies or procedures, give someone responsibility, make sure that this sort of education is happening routinely so people are used to and skilled at writing in plain English in discharge care plans. So if you didn't quite get the change that you're after at the end of this cycle, you might want to tweak your process and try it again. If you are happy, you might move on to your next idea to improve the readability of discharge care plans. Maybe you want to add in, drop-down boxes now or something like that to replace some of the free text fields. So that is the PDSA cycle. As with other parts of the improvement process, you want to be very specific in the plan for every test cycle that you run. So each change idea will have several cycles. You start really small with, a small number of people or in a small space, and then if that works, then you sort of scale up, and then you might try it in a different environment, and then when you're feeling really comfortable that this is great, this is working, then you're going to repeat it on a larger scale, and if you're still happy, that's when you can fully implement and standardize your change into practice. So in the impact phase, this is when you're going to be analysing your data and looking at the changes that you've made. So, at the end of your process, did you get the changes that you wanted and expected? So have you scaled up and tested changes on a larger scale, as I just mentioned? Did you tweak and improve? And did you manage to get where you wanted to go? You're only really going to know if you've collected data and kept a record of exactly what happened in each one of these cycles. So there are a lot of different ways that you might collect data. A really simple one is tally sheets. You just need a pen and a paper, and you can accumulate data about the frequency of events. Run charts, these are one of the most helpful tools in quality improvement because they show you data trends over time. So these are really handy for using with PDSA cycles. If you have an annotated run chart, you can have information on them as well. And in this one on the screen, you can see where the system changes in the wards came into play, and then you can see the impact that that's had on the data afterwards. So it shows, data shifts after that point in change. Control charts, that's something else that you could use, which show random variations. So once again, they're online, there are instructions on how to use them all, and there are a lot of different other measurement tools also, and I'm going to share the links for the websites where these are housed. So the final stage of improvement, the sustaining phase, looks at embedding and spreading the great work that you've done. So how are you going to ensure that your improvement's not lost? Standardise your process. Use education, use training, and make sure everyone's doing it the same way. Make it part of a form or documentation. Give someone responsibility for maintaining the improvement. And of course, regularly review your data that's related to this process. Also, check out IHI's 7 Spreadly Sins. This is a great document that gives you advice about how to sustain and then even spread the changes that have led to improvement, so you can share what you've learnt and others can benefit from that also. As a final piece of information to share, this is entirely anecdotal, but I do think it's worth sharing. Some stroke coordinators who've improved their site's performance in difficult areas have given us the following advice. Make friends with the people that you want to work with. For instance, if you want to make improvements in processes that happen in the emergency department, start by going there often. Make sure they know your name and your face, develop a rapport before you do anything else. start talking about patient outcomes, beyond the period when the patient is in ED. Talk about positive changes first. Consider setting up regular meetings with them and other teams involved in care so that you can all review cases together and talk about outcomes and where things went well and where you can make changes. Think also about the language used in discussions about aspects that didn't work so well. So if you come at it from the angle of how did we do, what changes could we make, so that it's very systems-focused language and avoids individuals feeling like there's blame for them. As I think both Helen and Julie have mentioned, celebrate the successes, celebrate the wins, say thank you. So here are some fantastic resources for QI that I would recommend. There are short courses you can take, lots of tips, tools and templates, newsletters, podcasts. I'll send these slides out at the end, so you've got all of these links. I'd just like to acknowledge before we finish up the Queensland StrokeLink team. A lot of what I've spoken about today has been taken from that successful model, and just want to acknowledge all of the teams involved who are on this slide here today, and especially the two state coordinators who deliver the program, Lisa Yates and Elizabeth Gregory. And that brings me to the end of the presentation, and so I will open up now for questions.
Thank you, Mel, and of course to Helen and Julie as well for a very informative presentation. It was really great to get the different aspects from data to influence and then some practical steps. Just looking in the chat, we have a couple of questions. We had one from Damien Dwyer, who unfortunately had to leave, but he was asking, can you try small iterative steps instead of a full project methodology? He said he thanked you for your engaging information and wanted to take nothing away from this, but I think he said a primary issue for people like himself is a lack of time and resources to manage improvement projects, and he knows that the failure rates of projects leading to sustained long-term process change, that's often difficult to maintain that given staffing and resources.
Yeah, I completely understand the huge challenges in those areas at the moment with both staffing and resources. And I think that it's an entirely legitimate and even in some ways ideal if you're kind of reviewing your data on, a regular basis in team meetings and sort of you're aware of sort of the, the guidelines and the change processes and all of that, and you're going to go through and take those iterative steps. I think that's absolutely a way that it could be done. Would you like to add anything, Helen or Julie?
I think I completely agree, and there are some things that do require a big project and lots of resources and a long length of time, but I think the best processes with in stroke teams where we've seen it work really well in top performing hospitals is where that improvement cycle that you talked about, Melita, is just embedded in how the team does their daily work every day. So as Julie showed, there's variation in performance between different health services, and some manage to do extremely well in some areas. And when we talk to those people, there's often just very good established processes of that everyday review of data, and just a collaborative look at it. How can we tweak? It might be a very small tweak. What about if we did this like this next time, and then to review it? I completely agree with Damien that unless you have some of these things sort of embedded in how you do everyday business, it's very hard to sustain. But absolutely, not all improvement needs to be a massive project. And I think speaking with my sort of health service leadership hat, there's not a lot of money, but we know that lots of improvements can be made by simplifying processes, working better as a team, concentrating on the main things without a lot of resources. And can I just say one more thing?
Please.
Melita and Lisa, I have been lucky enough to work at a couple of hospitals that have done very well at maximising their proportion of patients going to stroke unit care. And that's been achieved by just changing the culture, little by little by little, working with all the teams, giving feedback to the bed management and ED team about how it was great to get that patient to the stroke unit. You know, we were able to do it, again, framing things as positive, but just little by little working on changing the way things work. So, yeah, that's enough.
Thanks, Helen.
Thanks, Helen. I think you might have already touched on this, Helen, in your last answer, but we had another question from Anita, who said, what advice do you have when implementing changes or improvement project at a clinician level versus direction from a manager or coordinator level? So I don't know
I'll
if you
take that again. There's probably something to add to what I said, because I think it is important that you know, an organisation has a strategy and has principles and values and what's important across the whole organisation. So that needs to come down from the manager coordinator level. But I think you're absolutely right, Anita, that having someone direct change, thou shalt, and I said, is not a very effective way to have change. And I think the most effective change that gets embedded in practice has to have the collaboration and the buy-in of the team in finding the best solution to implement the strategy that's required. So I think you need a combination. You need to have support from your exec and managers, but you also have to work with your clinicians and your teams.
Thanks, Helen. I think we've just got time for perhaps one more question that's just come in on the Q&A. So how do you know which QI projects just need manager approval and MDT buy-in, and which one need ethics approval? The tricky one.
Yeah, so I think that, you know, sometimes that's unclear even to people who've been doing research and QI for a long time. And I think you'll find that your own ethics office, or if you're at a smaller health service, wherever there's support for research activity, will have some useful resources to help you work through that. So I know in my health service, there's a checklist for whether something is a quality improvement project or is research. And a lot of it has to do with whether you're collecting and analysing routine de-identified data, as opposed to actually having an intervention that might affect patients and would need their consent. So I think it's hard for all of us to look for guidance in your ethics office. If you're in doubt, a senior researcher or quality improvement person in your health service may be able to help you, or there may be someone from the ethics or research team that can, you know, chat through a project with you. But de-identified data, this sort of use of registry data and then improving your processes in a way that's just tweaking routine activity, like where you're going to put the patient in a bed, or you know, what order you're going to do your standard tasks in, those don't require ethics approval.
Thanks, Helen. Some great points there about tapping into your local resources to help guide you. Well, I think we're fast running out of time, so we might wrap it up for today. I would like to wholeheartedly thank our presenters today, who have shared a wealth of knowledge with the attendees here today. So thank you, Helen, Julie and Melita, and thank you to everyone for attending. We're really hoping to expand this further in the future to help you put some of these tips into action. So we'll let you know when that's coming up. You should have a survey pop up in your browser now. So we really encourage you to complete that short survey just to let us know what you thought of the presentation today, and also what you would like to hear from us in the future. So thanks again for your time, and we'll see you next time.
Thanks, everyone.